This conference will now be recorded.
Okay, shall we start? Yes. Can you hear me?
Yes, ma'am.
Yes, ma'am.
Okay. Okay. Good morning. Today we'll have a brief discussion regarding burns and its management. So coming to the introduction part, burn injuries can vary from small wounds that can be managed in OP clinic to injuries that results in multi-organ system failure. Burn injuries most commonly occurs in very young and old age people. In young, that is in children, scalp burns are most common, which occur due to pans, hot water, etc. In adults, mostly burns occur due to electrical and chemical injuries. Coming to the types of burns, broad classification is dermal injury, electrical injury, chemical injury, ionized injury, and sunburns. Under dermal injury, again there will be scalds, flame burns, flash burns, contact burns. Scalds are due to spillage of hot liquids. Flame burns are in kitchen hole burns. Flash burns occurs due to combustible liquids, natural gases. Contact burns are due to contact with hot metals or objects. So coming to the classification of burns. Burns are classified under first degree, second degree, third degree, and fourth degree burns. Second degree is again of superficial and deep. First degree burns, injury is localized only to epidermis. In second degree burns, superficial type is injury to epidermis up till papillary dermis. Deep is injury occurs till reticular dermis. Third degree burns are burns which injury occurs till subcutaneous fat. Fourth degree burns involves underlying muscles and bones also will be exposed here. See, you can remember it is like this. You know the skin has epidermis and the dermis. Beneath the dermis is the subcutaneous tissue. Epidermis is again having 5 layers. That is stratum corneum, lucidium, granulosum, spinosum, and basal. Dermis is again papillary dermis and reticular dermis. Okay. So involving only epidermis is the first degree. Up till the papillary is the second superficial. Reticular is the second degree. Deep involving subcutaneous tissue is the third degree. Beneath this involving the muscles is the fourth degree burns. The same here in the pictorial representation. See, epidermis is the first degree, superficial second degree is up till the papillary dermis, deep is the reticular dermis, third degree is the subcutaneous fat, beneath this is the fourth degree. The effects of the burns are influenced by the intensity of the energy, duration of exposure of the patient to the burns, and the type of tissue injured. So coming to the first degree burns, you can see in the image here, involves only the epidermis. These will be red and painful. No blisters will be present. No edema. Shows capillary filling. Heals rapidly in 5 to 7 days by epithelialization without any scarring. Coming to the second degree burns, under superficial, involves only papillary dermis. Blisters are present. Blanching will be present. Moist skin, pinprick sensation will be present. Heals without scarring in 2 weeks. Whereas deep second degree burns involves up to reticular dermis. This does not blanch. Sensations are decreased here. Pinprick sensations are present. Healed with hypertrophic scar within 3 or more weeks. Coming to third degree burns, this involves the subcutaneous fat also. There will be hard leathery feel. Charred black will be present. No blanching will be present. No capillary return. Completely anesthetized. Heals by reepithelialization from the wound edge. Fourth degree, you can see in the image, there will be eschar formation. It involves underlying tissues like muscles and bones. Bones will also be exposed in certain burns of fourth degree. The same here, the first degree you can see here involving only epidermis, second degree up till the dermis, third degree involving the subcutaneous fat also. So how do you assess? Burn size needs to be assessed in a controlled environment. Area should be exposed. Any soot or debris present must be removed and washed off. Care should be taken not to cause any hypothermia, because hypothermia causes lethal triad, which leads to death of the patient. So we should take precaution to not to cause any hypothermia to burns patients. So based on the size, larger burns, you have to draw London Browder chart, which maps out the percentage of total body surface area involved. Chart is based on the age of the patient, and this is the most accurate method. Smaller burns are, this is the second technique of estimating total body surface area using the patient's hand. The patient's hand represents approximately 1% of total body surface area, and total burn size can be estimated by determining how much of the patient's hand area is burned. Coming to rule of 9. WALLACE rule of 9, we usually see in our casualty, we assess the burns patient by using WALLACE rule of 9 only. This is the most commonly used method. It is used as a guide to assess total body surface area outside the hospital management. This is the London Browder chart. Depending upon the age of the patient, areas are divided. Maybe it is difficult for you to remember this. This is the WALLACE rule of 9. This you should remember. This is also based on adult and child. Only a minor difference will be present in both adult and child. In adults, head constitutes of about 9%. Right arm is 9% and left arm is 9%. Chest constitutes of about 18%. Back is also 18%. Right leg is 18%, left leg is 18%, and perineum is 1%. This total constitutes of about 100%. Coming to the child, only a difference is in child, the head and neck constitutes of about 18%. In adults, only 9%. Remaining all is same. So this extra 9% comes from this right and left leg. Okay. Here we'll have 18% in both right and left. Here we'll have only 13.5%. So this 9% from here is taken to here in child. That is the only difference. So this you should remember. Coming to the, based on the depth. Depth of the burn is dependent on the temperature, time of its contact, and the burning material. So 65 degrees Celsius, if we come in contact for about 45 seconds, then we'll have full thickness burn. If we get in contact only for 15 seconds, then deep thickness burns occur. For 7 seconds contact, we'll have only superficial thickness burns. So time of contact is also very important, and the temperature is also very important. So these are some of the causes of the burn and probable depth of the burn. Scalds usually cause only superficial burns. Fat burns cause deep dermal burns. Flame burns, mixed deep dermal and full thickness burns. Alkali burns causes full thickness burns. Acid burns are weak acids causes superficial and strong acids cause deep dermal burns. Among these chemical burns, that is acid and alkali burns causes full thickness burns. Okay. Electrical contact burns causes full thickness burns. So coming to clinical features. First, history of burns is very much important. Patients may present with pain, burning sensation. Patients may also present with tachycardia, tachypnea, fluid loss. Hypovolemic shock will be present. In severe degrees, shock is also present. Coming to pathophysiology, burn injury can damage in a number of ways, depending upon the route. Either it can be occurring through airway when burns to face or neck, lungs when trapped in house fire, in most common affected organ, through direct contact. So, injury to airway and lung. Injury to airway above larynx, the hot gases burn the nose, mouth, tongue, and palate, which starts to swell and interfere with the airway. The linings of the structures start to swell. Injury to airway below larynx. Steam got larger latent heat of vapor and thus it travel down and cause damage to lower airway by injury to respiratory epithelium, which detaches and forms cast, causing blockage to airway. So in these cases, early intubation is very much important because when this structure swell, it will cause difficult intubation. It may not be possible to intubate even. See, you can see the whole edema. Coming to metabolic poisoning, there are many poisonous gases given off in a fire, the most common being CO, a product of incomplete combustion that is often produced by fires in enclosed spaces. The person is found with altered consciousness at the scene of the fire. This carbon monoxide binds with hemoglobin with an affinity of 240 times greater than the oxygen and therefore blocks the transport of oxygen. Carboxyhemoglobin concentrations greater than 10% are dangerous, and these patients need immediate treatment with pure oxygen for more than 24 hours. Death occurs with concentrations around 60%. Another metabolic toxin produced in house fires is hydrogen cyanide, which causes a metabolic acidosis by interfering with mitochondrial respiration. Coming to inhalational injuries, inhalation of thick smoke usually has smaller particles, and these smaller particles directly travel down and they get attached to the alveoli, causing chemical alveolitis. This leads to edema, leading to impairment of gaseous exchange and respiratory failure. Mechanical block on rib movement. The eschar formed in the third and fourth degree burns. These cause this mechanical block on rib movement. Prevent the movement of the ribs. Coming to inflammation and circulatory changes. The changes occurs because burned skin activates a web of inflammatory cascades. The release of neuropeptides and the activation of complement are initiated by the pain fibers and alteration of proteins by heat. The activation of Hageman factor initiates a number of protease-derived cascades, altering like arachidonic acid, thrombin, and kallikrein pathways. Coming to the cellular level, the complement cascades degranulation of the mast cells and hosts the proteins altered by the burn. This attracts neutrophils, which also degranulate with the release of large quantities of free radicals and proteases. These can in turn cause further damage to the tissues. These mast cells release primary cytokines such as tumor necrosis factor alpha. These act as chemotactic agents to the inflammatory cells and causes the subsequent release of many secondary cytokines. These inflammatory factors alter the permeability of the blood vessels such that the intravascular fluid escapes outside. The increase in the permeability in such that large protein molecules can also now escape with ease. This leads to hypovolemic shock. These damaged collagen increase the oncotic pressure within the burn tissue, further increasing the flow of water from the intravascular to the extravascular space. The overall effect of these changes is to produce a net flow of water, solutes and proteins from the intravascular to the extravascular space. This flow occurs over the first 36 hours after the injury but does not include the red blood cells. In case of a small burns, this reaction is small and localized, but as the burn size approaches 10 to 15% of total body surface area, the loss of intravascular fluid can cause a level of circulatory shock. So these patients need to be hospitalized for fluid management. Coming to other life-threatening events with major burns. So what happens with the immune system and the infection? Cell-mediated immunity is decreased in large burns, leaving them more susceptible to bacterial and fungal infection. The most common bacteria is Pseudomonas. There are many potential sources of infection, especially from the burn wound. Okay, and also from other sources like the catheters, that is central venous lines, next tracheostomy tubes and Foley's catheters, etc. So we have to take care regarding not only the burn wound but also all these catheters and etc. So what happens to the intestine? Due to this hypovolemic shock, there will be ischemia to the gut. This reduces gut motility and prevents the absorption of fluid. So failure of enteral feeding in a patient with a large burn is a life-threatening complication. This process also increases the translocation of bacteria from the lumen, which become an important source of infection in large burns. Gut mucosa swelling, gastric stasis, and peritoneal edema can also cause abdominal compartment syndrome, which splints the diaphragm and increases the airway pressures needed for respiration. Coming to peripheral circulation, in full thickness burns, the collagen fibers are coagulated, the normal elasticity of the skin is lost. A circumferential full thickness burn to a limb acts as a tourniquet as the limb swells. If untreated, this will progress to limb-threatening ischemia. So, eschcharotomy should be done in these cases. So, coming to the injury to the skin, burn injury causes coagulation necrosis, and thus three zones are formed: zone of coagulation, zone of stasis, and zone of hyperemia. This zone of coagulation is where the burn is directly contacted and the tissue is necrotic in cases of zone of coagulation. Zone of stasis, here there will be release of inflammatory mediators and there will be vascular damage which leads to vasoconstriction, and this zone of stasis should be noticed so that it will not progress to zone of coagulation. In case of zone of hyperemia, there will be increased inflammation and there will be vasodilation so that more vascularity will be coming. So if you cannot remember the previous slides, you have to just remember this pathophysiology. Heat causes coagulation necrosis of the skin and subcutaneous tissue. This releases the vasopeptides. This causes alteration of capillary permeability. Due to this loss of fluid from intravascular compartment, this leads to severe hypovolemia. This leads to decreased cardiac output. When there will be severe hypovolemia, this leads to decreased myocardial function. This decreased cardiac output leads to decreased renal blood flow due to renin-angiotensin activation. This decreased renal blood flow leads to oliguria. And this decreased cardiac output, there will be altered pulmonary resistance causing pulmonary edema, which is more prone to infection. Next, SIRS will be developing. Finally, it brings to multi-organ dysfunction syndrome. So how do you manage? So in case of burns, pre-hospital care is also very much important. So first, you have to ensure vascular safety first. First, stop the burning process. By stop, drop and roll, standard airway, breathing and circulation should be maintained at the pre-hospital care only. Cool the burn wound by running tap water for 10 minutes within 1 hour of burn injury. So give oxygen supplementation. Elevation of head with burn area is life-saving. Elevation of limbs to reduce any further swelling and discomfort. So, what is the criteria for the hospitalization of burns patient? If you suspect any airway or inhalational injury, the patient should be admitted. Any burn likely to require fluid resuscitation. Any burn likely to require surgery. Patients with burns of any significance to the hands, face, feet, or perineum. Patients whose psychiatric or social background makes it inadvisable to send them home. Any suspicion of non-accidental injury. Any burn in a patient at extremes of age. Any burn with associated potentially serious sequelae, including high-tension electrical burns and concentrated hydrochloric acid burns. So these are the criteria for the patient for acute admission. Coming to hospital care. Any patient, any burns patient who arrives to your hospital, if you see any case in a casualty, so first you have to make sure to see this. any trauma case or any burns case, which is an emergency, we have to take care of. There is two things in the trauma. That is first the primary survey and the secondary survey. The primary survey includes A, B, C, D, E, F, except for cardiac, which C comes first. That is C, A, B. In all other cases, A, B, C, D, E, F is seen. So A is the airway control. First, most important is the airway control. Second is breathing and ventilation. Third is circulation. D is disability. E is exposure. F is fluid resuscitation. We have to remember not only in case of burns but also in trauma. The primary survey includes A, B, C, D, E, F. Secondary survey is specific. So evaluation of the burn patient. On arrival, a thorough evaluation is performed and a treatment plan is developed. So burns patients are trauma patients and they require evaluation in accordance with the ATLS protocol, that is Advanced Trauma Life Support Protocol. So airway, breathing and circulation are assessed immediately following burn injury. In addition to ensuring a patent airway, adequate breathing and circulation, the presence of additional injuries, particularly life-threatening injuries, should be excluded. So after this, now comes the secondary surgery. We have to take a thorough history. Following the initial resuscitation, a detailed history of the burn should be taken as it may provide important information that will affect management. It includes location of the injury, whether it is an indoor injury or outdoor injury, type of liquid involved in a skull burn, duration of extraction from the site, details of the patient's other medical problems. Comorbid is also very important. Now we have to examine the patient. So this includes determination of burn extent and depth of burn injury. We have already seen these both. WALLACE rule of thumb. Okay, how much percentage of burn is present. Next, depth of injury. Coming to fluid resuscitation. In burns, fluid resuscitation plays a very much important role. We will see hypovolemic shock due to shift of intravascular fluid to extravascular compartment. So, this principle of fluid resuscitation is to maintain intravenous volume in order to provide sufficient circulation. Fluid resuscitation provides adequate replacement for fluid lost to the skin and fluid lost into the interstitium from the systemic capillary leak that occurs as a part of body inflammatory response. So, in children with burns over 10% of total body surface area and in adults with burns over 15% of total body surface area requires fluid resuscitation. If we prefer oral fluids, then salt must be added to this oral fluid to the patient. So what are the crystallars and colloids? The crystallars, we usually prefer RL, ringal lactate. Ringal lactate is relatively hypotonic and contains sodium, potassium, calcium chloride and lactate. Crystalloids are used effectively to maintain intravenous volume. In children, normally dextrosaline is given as 100 ml per kg for 24 hours, first 10 kgs, and for the next 10 kgs we give 50 ml and 20 ml per 24 hours for each kg over 20 kgs of body weight. If you not remember all the formulas, please do remember Parkland formula because we usually follow this Parkland formula in our consultations. This is the most commonly used formula to calculate amount of fluid to be replaced. It is also easy to remember. It is 4 ml into weight in kilograms of the patient into percentage of total body surface area involved. But the maximum percentage considered is only 50%. More than 50% also of burns also we will not consider more than 50%. Half of the volume is given in the first 6 hours and remaining half is given in the next 16 hours. So you have to divide according to this. Another formula is the Western formula. This uses 5000 ml per total body surface area burned in millimeter square plus 1500 ml per meter square total for maintenance in the first 24 hours. This is usually used in the children. This formula accounts for maintenance needs, the increased fluid requirements of a child with a burn. Coming to colloids. The use of colloid has the advantage of increasing intravascular oncotic pressure. We have seen previously, the intravascular oncotic pressure will be decreased. So this colloids increases the intravascular oncotic pressure, which could minimize the capillary leak and potentially draw fluid back intravascularly from the interstitial space. So albumin is the most oncotically active solution and does not carry a risk of disease transmission. The most common colloid-based formula is Muir-Berkeley formula. Here, 0.5 into percentage of body surface area burned into weight. This is taken as one portion. So, this into 3. That is, 3 portions is given in first 12 hours, 2 portions is given in second 12 hours, 1 portion in the third 12 hours. Okay. Muir-Berkeley formula includes colloids. Remember this. So this is the brief representation, Parkland, group and galveston. So you are giving fluids. So we have to monitor the resistivity, whether it is adequate or not. So the key for monitoring is urine output. It is done to check whether adequate fluid is there. Police catheter is used. Urine output should be between 0.5 to 1 ml per kg in body weight per hour. Should not be more than 2 ml per kg body weight per hour. So coming to the topical agents. So what should we do with the burnt area? So initially dressings with non-adherent material like Vaseline impregnated gauze or Mepitil and left for 5 days, which heals after 7 to 10 days. Initially we have done this. Then silver sulfadiazole is commonly used dressing, but this is contraindicated in pregnant women, nursing mothers, and infants less than 2 months, and there is increased possibility of Kernick case. So in case of a minor burn, how do we do a dressing? The aim of this dressing is to decrease the wound pain and to protect and isolate the burn. Bulking of the dressing wound depends on the amount of discharge. Synthetic burn wound dressings are popular as these decrease the pain associated with dressings, these improve healing, decrease the OP appointment, and overall cost will also be decreased. This is the BioBrain, is a synthetic material that is bilamellar dressing done in cases of burns which are fresh, sensate, show capillary blanching and refill, removal of all blisters. It is impervious to gases but not to fluids and bacteria. Hence, every 48 hours we should be checked for adherence and infection. So BioBrain, remember this synthetic dressing. You have to do TT prophylaxis. Any RTA case or any burn case, you have to follow this TT prophylaxis. Okay. All patients with burns of more than 10% of total body surface area should receive 0.5 ml of TT. If prior immunization is absent or unclear, or the last booster dose was more than 10 years ago, 250 units of tetanus immunoglobulin is also given. So surgically, how do you treat burning? Eschcharotomy is done. Full thickness burns and obvious deep dermal burn wounds forms the eschar, so we have to do eschcharotomy. Superficial partial thickness wounds and mixed deep depth wounds may also form this. The eschar of a full thickness burn can form a constricting band that comprises limb perfusion. We have already previously seen this. Eschcharotomy is indicated for full thickness circumferential burns of extremity. Adequate release occurs when the eschar separates perfusion improves. The burn needs to be clean, size and depth needs to be assessed. And this burn depth and size should be not only assessed during the first visit, that is in the casualty, but we have to see it regularly. Full thickness burns and deep partial burns require operative treatment, need to be dressed with antibacterial dressing to delay colonization, or else the patient will be susceptible to infections. This should be done in mid-axial plane to avoid major nerves in space. So eschcharotomy can cause large amount of blood loss. So if required, blood transfusion should also be kept ready. So what are the indications for this eschcharotomy? In upper limb, it is mid-axial, anterior to the elbow, medially to avoid the ulnar nerve injury. In hands, midline in the digits, release the muscle compartments in its side, best done in theatre with an experienced surgeon. In lower limbs, it is done mid-axial, posterior to the ankle, medially to avoid the saphenous vein. In chest, down to the chest, lateral to the nipples, across the chest, below the clavicle, and across the chest at the level of episternum. General rules followed are extend the wound beyond the deep burn diathermy. Any significant vessels are present, apply hemostatic dressings, and elevate the limb post-operatively. Just remember this image. In hands, among the chest and legs mid-axial, and this is the fingers. Main aim is to prevent the eschar forming the constricting band. So eschharotomy is done among these lines. So you can see here. Or else this prevents the rib movement, which leads to respiratory failure. Coming to topical antibiotics, available topical antibiotics are divided into salves and soaps. So what are these salves? These salves are directly applied to the wound with cotton dressing over them. So both for salves and soaps, there is advantage and a disadvantage. Coming to disadvantage of salves is we have to directly apply to the wound. So there will be more of dressing changes. Okay. Loss of grafts or loss of underlying healing cells due to frequent changes of the dressing. Examples of these salves are 1% silver sulfadiazine, 11% methenamide acetate, polymyxin V, neomycin, bezitracin, mepirocin, and nystatin. These are the examples of salves. Coming to soaps, once dressing is done and these soaps can be poured over the dressing only. So this is the advantage. We need not remove the dressings for more times. Unlike the salves. So in soaps poured into the dressings on the wound. Advantages are effective because solution is added without the removal of dressings. So what are the disadvantages? Underlying, so we will not remove the dressings frequently. So we don't know whether the underlying skin is normal or it is macerated. So this is the disadvantage in soaps. Coming to examples of soaps are 0.5% silver nitrate, 0.025% silver hypochlorite, that is vacuum solution, 0.25% acetic acid, 5% solution of methanic acetate. So coming to the full thickness and deep dermal wounds. So what are the dressings usually preferred in this? Dressings with nanocrystalline silver, silver sulfadiazine cream 1%. These are effective against pseudomonas and methicillin resistant staph aureus. So advantages are painless and easy to apply, high patient acceptance, broad spectrum of antimicrobial activity including gram-positive, gram-negative, and some fungal forms. Coming to disadvantages are because of the silver, they will stain black. So they may leave black tattoos from silver ion. Mild inhibition of epithelialization. Transient leukopenia after 3 to 5 days of use. It is generally harmless and resolves with or without treatment cessation. Does not penetrate eschar. So methanide acetate cream, that is 5% topical solution. These are also useful against pseudomonas and enterococcus infection. Advantages are this can penetrate eschar, broad spectrum antimicrobial activity. Disadvantages are they may cause pain and insensitive skin, metabolic acidosis due to inhibition of carbonic anhydrase, hence used in small partial thickness burns. Mild inhibition of epithelialization may be present. Allergic rash. Silver nitrate solution, that is 0.5%, effective against pseudomonas. It is less effective than silver sulfadiazine cream. It needs to be changed or wounds re-soaked for 2 to 4 hours. Advantages are these are painless on application. Again, disadvantages are silver. Silver obviously causes staining on the surface. A new commercial dressing containing biologically potent silver ions anticoats that are activated in the presence of moisture is available. These dressings hold the promise of retaining the effectiveness of silver nitrate without the problems. Coming to sodium nitrate and Dakin solution. Sodium nitrate are used especially for tooth-thickness burns. They form a sterile postcard and boost cell-mediated immunity. This is effective against, Dakin solution is effective against almost all microbes, particularly gram-positive organisms. These mildly inhibit epithelialization. So superficial partial thickness wounds and mixed depth wounds. In superficial burns, these usually heal among 2 weeks or within a week, and they may need simple dressings. They heal irrespective of the dressings. Dressings must be easy to apply, non-painful. They should reduce the pain, simply to manage, and locally available. The choice of dressing can make the difference between scar and no scar, and operation or no operation. So, what are the options for dressings? Permeable wound dressings, Methixor, Fixamol, Vaseline impregnated gauze, or fenestrated silicone sheet material, Mepital. These are packed with swabs to absorb exudate. Another type of dressing is hydrocolloid dressing, which is very useful. These are used in mixed depth wounds as the high protease levels aid in the debridement of deeper areas of the burn. These provide moist environment for epithelialization. These are changed for 3 to 5 days. Deoderm is a type of hydrocolloid dressing. And we have already previously seen the synthetic biogreen. These are the types of dressings, either biological dressings or synthetic, that is biogreen, and natural, that is amniotic membrane. These all provide good healing, especially in superficial partial thickness burns. They even cause only less scarring. So these are very much useful. So you might only know what are the salts and sores previously in burns. You have to remember these also. Biological dressings, synthetic dressings like biogreen, and natural like amniotic membrane. Others are hydrocolloid dressings. You can see here. The child has some scar. From boiling water, he has a scar. So on frequent dressings with hydrocolloid, there is very, very minimal scar. So these are very much useful. Coming to treatment of burns, analgesia is very much important. So among analgesia, there is acute, subacute. Among acute, for superficial burns, in case of acute, you can use simple oral analgesics like NSAIDs. Large burns, IV opiates are very much important. Usually, IM are not preferred for these burns. Coming to subacute, in large burns, continuous analgesia beginning with infusions and continuing with oral tablets like slow release morphine. Before dressings also, analgesia should be administered. For the burns, not only the wound, energy balance and nutrition is very much important because they will be more in a catabolic state. So we have to give nutrition for the patient. The burn patients need extra feeding. Hypermetabolism and hypercatabolism both occur following burn injury. So feeding should start within 6 hours of the injury to reduce mucosal damage. So early enteral feeding should be done. Nasogastric tube should be used in all patients of burns over 15% of total body surface area. Removing the burns and achieving healing to stop catabolic drive. So how do you monitor and control the infection? Patients with burns have enlarged portal of entry to the pathogenic and opportunistic bacteria and fungi. These makes them immunocompromised. Compromised local defenses in lungs and guts are due to edema. Monitoring IV lines, catheters themselves represent portal of infection. So a rise in WBC count, thrombocytosis, and increased catabolism are warning signs of infection. So we have to send this investigations either daily or alternate day. Sterile precautions must be rigorous. Swabs are taken regularly and antibiotics should be started as soon as the patient gets admitted. And culture sensitivity should be sent from the wound. Other care is nursing care. Nursing care is also very much important. Burns require ICU nursing care. Nurses are the primary effectors of many decisions that directly affect healing. Next is the physiotherapy. Burns needs physiotherapy. Elevation, splintage, and exercise reduce swelling and improve the final outcomes. Physiotherapy should be started on day one and massage can be reinforced on daily basis. Psychologically, these burn patients will be depressed, so psychological support should be given to these patients. These are normal and usually self-limiting, receding as patients heal. The features of this intensity of experience are of intrusive reactions, arousal reactions, and avoidance reactions. So, what is a part of surgery for acute burn? Any deep partial thickness and full thickness burns, except those less than 4 centimeters per square, 4 centimeters square, need surgery. Any burn of indeterminate depth reassist after 4 hours because burns that initially appear superficial may deepen after some time. These delayed microvascular injury common in scars. So we have to assess the burn depth frequently. So essence of burn surgery. A wide bore cannula, BP monitoring. If large excision is considered, then we have to prepare an arterial line for BP monitoring. Central venous pressure monitoring should be done. Acid test balance should be clean. Clotting time and HB level. Temperature should not be below 36 degrees Celsius. We have already previously seen the hypothermia should be avoided in case of burns. So for most burn excisions, we have to see for controlling the bleeding. Subcutaneous injection of adrenaline can be given, or we can either have a tourniquet control. For deep dermal burns, the tangential excision can be done. Later, after the wound is normal, then we can put a skin graft. For full thickness burns, also excision is done initially. Later, when the wound is healed, then we have to see for culture and sensitivity. Then we can put a skin graft. Large burns, synthetic dermis or homograft as a temporary stable coverage can be done. These are the full thickness burns. Prior to eschharotomy and later the eschharotomy is done and we have to do regular dressings. Later when the wound is healed, then we can do a skin graft. Coming to facial excision. This is used in burns extending down through the fat into the muscle, large infection wound, life-threatening invasive fungal infection using Rowland knives and number 11 plates up to fascia. Leaves a permanent contour defect that is impossible to reconstruct. In these cases, obviously the lymph channels are excised. This causes peripheral lymphedema. So, we have already previously seen the burn dressings. So, what are the surgeries done to the burn wound and later how the burn wound is covered. We know any ulcer or wound which is raw area and it is ready for grafting, we usually use split skin graft. If split skin graft is not possible, then flaps are used. Various biological and synthetic substrates are employed. Biological, autograft, allograft, xenograft. Autograft is taken from uninjured skin. It is difficult when full thickness burns exceeds 40% of total body surface area. Allograft is usually taken from cadaver skin or homograft. Completely provides all the normal functions of the skin, can leave a dermal equivalent. Disadvantages are risk of antigenicity and cross reaction and limited availability. Xenograft is usually taken from thick skin. Synthetic substrates are integra, opsite, transite, biobrain are commonly used. Cultured epithelial autografts. Autologous epithelial cells are grown from a single full thickness skin biopsy specimen have been available. That is, a skin biopsy is taken from the person and this is grown from this. So disadvantages are poor long-term clinical results, exorbitant cost, fragility, difficult handling. Epithelial autografts used in combination with white mesh autograft and allograft overlay in children with burns of 90% total body surface area has improved cosmetic results. See, this is the skin closure using widely meshed autographs. You can see here. This is the excised wound bed. This mesh is done with 4:1 meshed autograph. Okay. Thin grafting is taken and then 4:1 ratio meshing is done. That is, these gaps are called as mesh. Next is 2:1 mesh is done. Coming to post-operative. Post-operatively, fluid balance should be maintained. Levels of hemoglobin should be checked. Dressings are changed on regular basis. We have to prevent the infection. Elevation of limb is very much important to prevent edema. Physiotherapy and splint for range of movements, because contractures is the most common complaint when the burn involves the joint. Next, splints. Hands splinted in a position of function after grafting. Knee should be in extension, axilla should be in erection. So what are the complications of burns? Ectropion of eyelid causing keratitis and corneal ulcer. Disfigurement of face, narrowing of the mouth, that is microstomia. Contracture in neck causing restricted neck movements. So this should be prevented by early physiotherapy. We have already previously discussed. Disability and non-functioning of joints due to contractures. Hypertrophic scar and keloid formation can occur. Repeated breaking of scar and infection, ulcer, cellulitis. Pain and tenderness in the scar contractures. Marjolin ulcer, this is a well-differentiated squamous cell carcinoma. We see in a prolonged burns only. Thank you. Have everyone given your attendance in the chat box? Yes?
Yes, ma'am.
Okay then. I'm
Yes,
closing the
ma'am.
meeting.